I call the meeting to order. Welcome to meeting number 10 of the House of Commons Standing Committee on Health. Today we will be meeting until about 6 p.m. Eastern to hear from witnesses on our study of Canada's health workforce. I understand Dr. Tomlin Murphy has to leave at 5:40, so I would encourage those who have questions for Dr. Tomlin Murphy to pose those questions before 5:40. Today's meeting is taking place in a hybrid format pursuant to the House Order of November 25th, 2021. All of the members of the committee are present in the room, but the witnesses are on the Zoom application. For those of you who are using the Zoom application, please do not take any photos of your screen or screenshots. We will be respecting all of the healthcare directives from the Board of Internal Economy and the public health authorities. I can inform the members of the committee that all of our witnesses today have completed the required connection tests in advance of the meeting. And to our witnesses, let me say first, welcome. You will each organization will be given 5 minutes to make their opening statements before rounds of questions. Colleagues, we have with us here today from the British Columbia Pharmacy Association, Geraldine Vance, Chief Executive Officer; from the Canadian Nurses Association, Michael Villeneuve, Chief Executive Officer; and Dr. Gail Tomlin Murphy, Vice President of Research, Innovation and Discovery and Chief Nurse Executive for Nova Scotia Health. From the Kingston Health Sciences Centre, Dr. David Pecora, President and CEO. From the Ontario Medical Association, Dr. Adam Kassam, President, and Dr. James Wright, the Chief of Economics, Policy and Research.
Mr. Chair?
Yes.
It looks like there's going to be another vote, and just instead of interrupting the witnesses, I just see if you could seek the unanimous consent now that we proceed through bells, and so members could vote electronically with a brief pause until we get the result once those bells start.
Okay, so thank you for that, Mr. Barrett. Do we have the consensus to proceed through bells and to suspend briefly to allow people to vote using the app? Great. Thank you, Mr. Barrett. Thank you, everyone. We have consensus on that.
Mr. Chair, on that point, for today, I'll say yes, because we've already started this meeting to some degree, but my whip has told me that I needed to tell you that the right to vote in the chamber is a privilege, and that in this regard, someone who would want to or choose to do so, that should be respected. So for today, I agree to this, but in the future, we'll have to be careful because I should, in theory, be in the House. Thank you. That's clear.
Okay, so now to our witnesses. First of all, thank you for your patience. The delay, as you know, was caused by a vote in the House, and just through unanimous consent, we've agreed that there won't be another delay because there is going to be another vote, but there will be a brief interruption. So thank you for your patience. Thank you for being here with us. We're going to start off with rounds of opening statements, beginning with Ms. Vance. You have the floor for 5 minutes.
Thank you. I want to acknowledge that today I'm speaking to you from the traditional territories of the Squamish, the Tsleil-Waututh, and Musqueam First Nations. The COVID pandemic has shown both the weaknesses in our healthcare system and the resilience of our healthcare providers who have worked for the last 2 years to meet the unprecedented demands the pandemic has placed on them. It is clear that the federal and provincial governments must renew their commitment to providing the support needed to ensure that Canada has the physicians, nurses, and other healthcare providers ready to face another health crisis of similar magnitude should it come. The BC Pharmacy Association applauds the work of this committee in pursuing much needed opportunities to recruit and retain a diverse team of healthcare professionals across Canada. Today, I want to share the perspective from my province, British Columbia, on the resilience community pharmacists have demonstrated. As committee members will well know, BC has been particularly hard hit since COVID-19 pandemic was declared. This health emergency was layered on top of BC's other public health emergency, the opioid crisis. And added to that, our province faced a once-in-a-lifetime set of wildfires, heat domes, catastrophic flooding, and all of that has added to the stress on the province's healthcare system. It is a testament to every healthcare worker in our province that has worked to ensure that despite the cascade of obstacles, that people in communities big and small receive the care they needed. We all know that healthcare workers have paid the price. They are spent, and they need to know that their governments will put plans in place to make them better able to meet the next crisis. And a key part of that preparation is the work of this committee, recruitment and retention of healthcare professionals. When BC went into a public health state of emergency in March 2020, which included a lockdown on all but essential services, pharmacies were the only community care settings that patients were able to access in person. Pharmacists quickly pivoted to ensure that they met the needs of their patients. BC has more than 1,400 community pharmacies in 158 communities across the province, and nearly every community has a pharmacy within a 30-minute drive. Pharmacies have long served as an important point of first contact for patients seeking medical care. A 2018 review showed that community pharmacists see their patients anywhere between 1.5 and 10 times more frequently than their primary care physicians. And we know that this number has skyrocketed over the last 2 years. This has meant more and more patients are calling on their pharmacists to answer questions to fill in gaps of in-person care. In a 2021 national survey, 90% of Canadians said that pharmacy professionals and pharmacies were essential during the COVID-19 pandemic. 3 in 4 Canadians said that pharmacists played a larger role in providing healthcare services than before the pandemic. And in that same survey, 93% of Canadians would trust pharmacists to be the first point of contact in the healthcare system. While community pharmacists fill a number of critical roles, there is much more that pharmacists can and should be doing. But unfortunately, pharmacists' scope of practice varies greatly from province to province, leaving a patchwork of coverage and patients in different jurisdictions unable to receive the same access to care. In 6 provinces and 1 territory, pharmacists have the ability to prescribe for self-limiting conditions like cold sores and acne. These self-limiting ailments are easy to treat and self-identifiable by the patient. In our view, a national scope of practice for pharmacists should be adopted that ensures all pharmacists are able to deliver the same care at their maximum level of expertise. And this would include prescribing rights. This is particularly important in rural and remote communities that continue to have difficulties in attracting physicians and other healthcare providers. Allowing pharmacists to practice at their full scope will help patients and those providers already struggling under the pressure of providing care. Governments have long struggled to harness the expertise of community pharmacists and to leverage the expansive network of community pharmacies. The pandemic has provided opportunities for pharmacists to show that potential exists. In BC, pharmacists have been critical in delivering COVID-19 vaccines. We believe that the federal government should target funding to the provinces that would be used to improve and harmonize a standard scope of practice across the country. We recommend that this committee create a forum of engagement with the Canadian Pharmacists Association and other provincial pharmacy associations to develop a strategy to fully employ the expertise of community pharmacists. Thank you very much.
Thank you, Ms. Vance. Next, we're going to hear from the Canadian Nurses Association. Would it be Mr. Villeneuve or?
Yes, thanks very much, Mr. Chair.
You have the floor for 5 minutes. Go ahead.
Mr. Chairman, just a small point of order regarding the speed at which these presentations were made. I realize that witnesses do not have much time, but the speed is such that the interpreters are having to keep up, and it is making it very difficult for interpreters to do their work. It might perhaps be better to slow down a bit so that we can understand better and we can get back to some points through the question period if there is anything that needs to be further addressed. Thank you. Thank you, Mr. Taillou.
Mr. Villeneuve, you have the floor for 5 minutes. If you go a little over 5 minutes, because we're going to ask you to slow down a little bit just to make sure that the interpretation picks it up, I'll cut you some slack. Yeah, go ahead. You have the floor.
Thank you, Mr. Chair, and members of the committee for inviting the Canadian Nurses Association to appear here today. We applaud the committee's decision to conduct this important and timely study on Canada's health workforce, and we hope the work of members of this committee can help lead to meaningful and much needed action. Pardon me. My name is Michael Villeneuve. I'm the Chief Executive Officer of CNA, and I'm speaking to you today from the traditional lands of the Algonquin and Anishinaabe people in Eastern Ontario. I'm pleased to be joined by Dr. Gail Tomblin-Murphy from Nova Scotia Health. Gail is an expert in the science of health human resources and is chair of the Royal Society of Canada Working Group on the impact of COVID-19 on the nursing workforce. Mr. Chair, I first stepped into healthcare as an orderly in 1978. And during my 44-year career, I have never seen anything like what the nursing profession is going through now. Canada's nearly 450,000 nurses are the backbone of our health systems, but they're completely exhausted, demoralized, and we're seeing many of them leaving their jobs and even leaving the profession. 94% of nurses say they're experiencing symptoms of burnout. Severe burnout among all healthcare workers has nearly doubled. There are close to 120,000 vacancies in the healthcare and social assistance sectors. And we've seen alarming rates of nursing vacancies in hospitals across Canada. These issues are not new, but they've been exacerbated by the pandemic. Nurses have been sounding the alarm for decades on these very same problems, long before COVID-19. There have been studies, reports, and literally millions and millions of dollars in research, all pointing to some of the very same core problems and many of the same solutions. In modeling work done by Dr. Tomblin-Murphy in 2009, CNA predicted Canada would be short 60,000 nurses by 2022, and here we are with the crisis we're living in now. We know that many of the solutions needed to stabilize the workforce. Canada needs a strong, modern, pan-Canadian health human resources strategy. Additional targeted federal funding is needed to help healthcare systems retain, recruit, and provide for adequate levels of staffing. The federal government has an important leadership role to play in ensuring Canada's health system is sustainable. It needs to work collaboratively with the provinces and territories on both short and long-term strategies. In the short term, we need retention incentives for nurses and healthcare workers to stay on their jobs. Could include retention bonuses, loan forgiveness, tax incentives. Additional funding to the provinces and territories should also be provided to help optimize workloads for healthcare workers. This could include increasing admin staff, for example, in nursing settings to unlock more time for care. In the longer term, CNA endorses calls for a national health workforce body that would be responsible for collecting high quality to support workforce planning at regional levels. CNA also recommends increasing training and education for healthcare workers by enhancing the number of seats in schools of nursing and increasing capacity for clinical placements for nurses. Finally, we recommend strongly the development of a national mental health strategy for healthcare workers, which would include funding for mental health supports. I'll conclude, Mr. Chair, by saying that in an emergency room, one of the first things you do is stop the bleeding. And that's what Canada's health workforce needs right now. We need emergency and definitive interventions with immediate action, and then a multifaceted strategy to address the complex problems of Canada's health workforce. Thank you, Mr. Chair. It's almost harder to do it slow. I'm stumbling over my words. Dr. Tomblin-Murphy and I will try to answer any questions. Thank you.
Thank you, Mr. Villeneuve. Next, we're going to hear from the Kingston Health Sciences Center. I don't know why I'm having trouble with that word. Dr. Pecora, you have the floor for 5 minutes.
Good afternoon. Mr. Chair and committee members, thank you for this opportunity. I'm speaking to you today from my perspective as a tertiary hospital CEO, an orthopedic surgeon, and a professor at Queen's University. Like our peer hospitals, Kingston Health Sciences Center has many complex and integrated roles. KHSC is both a community hospital and a large regional academic center, providing specialized tertiary services to urban, rural, and remote communities across a wide area of eastern and northern Ontario. During the pandemic, we doubled our ICU capacity and stepped up to be a critical care partner in the life-saving Team Ontario Critical Care Network. We accepted approximately 150 critically ill patients from the GTA, Northern Indigenous communities, and Saskatchewan. In addition, with Queen's University and St. Lawrence College, we train large numbers of physicians, nurses, therapists, and technologists. We have developed innovative partnerships like our federally and provincially funded Winnebago Area Health Authority, Queen's and KHSC program that provides access to the full range of healthcare services and training of frontline workers for the James Bay region. Like other tertiary hospitals, we have a research institute that partners in healthcare research with Queen's and with other universities across Canada and globally. All KHSC attending physicians have a Queen's faculty appointment. Beyond our direct roles in healthcare delivery, leadership, and innovation, hospitals have a substantial economic impact. We are major employers in our communities. We support a host of affiliated supply chain, pharmaceutical, and medical device industries, and we drive research and development. Previous speakers of this committee have illustrated how the pandemic has exposed and exacerbated longstanding healthcare human resource deficits and burnout. Canada is not alone in this crisis. The USA, for example, is experiencing high levels of burnout and projected deficits of 122,000 physicians and 1.2 million nurses. Other countries will be aggressively competing for our top clinical and research talent, and we need to stop training regulated healthcare workers for export and ensure that this precious resource is enabled and incented to live and work in Canada. Those of us working at the front line in hospitals have witnessed 2 decades of disinvestment, with continuing pressure to reduce expenses, reduce beds, and divert scarce resources to community and independent health facilities. Health human resources consume 70% of hospital budgets, so inevitably funding cuts lead to staffing reductions. The ongoing pandemic has highlighted the critical role that hospitals play in the health system performance and delivering value for money. During the pandemic, hospitals have been the backbone of our healthcare system. We rescued long-term care homes, anchored IPAC hubs, provided PPE to community partners, created assessment and vaccine clinics, created and adopted digital and virtual platforms, developed and implemented extender roles to mitigate HHR shortages, and pivoted to build new critical care and inpatient capacity. Any future interventions to address HHR challenges and pandemic recovery must acknowledge and respect and support the contributions that hospitals make. Mr. Chair, at our Kingston General Hospital site, some of our staff still work in the same building that held the very first meeting of the Parliament of Canada in 1841. For us to attract and retain the best and brightest, we must address the mounting infrastructure deficits and modernize our aging facilities and equipment. To mitigate burnout, healthcare workers must be able to see purpose and achieve fulfillment in their roles while having adequate workspace and work-life balance. These objectives require modern hospitals with modern equipment. The Government of Ontario is taking steps to invest in hospitals and long-term care facilities, but much, much more will be needed to assure safe and high-quality care. A human resource and infrastructure challenge of this magnitude requires strategic commitment and action by the federal government. Thank you.
Thank you, Dr. Pecora. Next, we're going to hear from the Ontario Medical Association. Dr. Kassam, will you be speaking?
Yes, I will.
Okay. Welcome to the committee. You have the floor for the next 5 minutes, sir.
Well, good afternoon and bon après-midi. My name is Dr. Adam Kassam, President of the Ontario Medical Association, and I am joined by Dr. James Wright, Chief of the OMA's Economics Policy and Research Department. On behalf of Ontario's 43,000 physicians, residents, and medical students, we appreciate the opportunity to provide a physician perspective on arguably the greatest immediate risk to the viability of healthcare in Canada, which is to say burnout of healthcare professionals. Physician burnout is primarily caused by stressors in the workplace, including inefficient work processes and environments, and clerical burden. In other words, the inefficiencies and obstacles in the healthcare system not caring for patients are the major contributors to burnout. In fact, the OMA established a burnout task force in 2019. Its objectives physicians, residents, and medical students to understand the extent of burnout and then to identify specific solutions. In March of 2020, prior to the pandemic, a shocking 29% of Ontario physicians reported high levels of burnout, while another 2/3 reported some level of burnout. By March of 2021, of course, 1 year into the pandemic, that number was even higher, with 35% reporting high levels of burnout and almost 3/4 reporting some level of burnout. Ontario physicians face years of working above capacity just to clear the pandemic backlog of more than 21 million delayed medical services, let alone reducing the wait times that have plagued the system for decades. Attempting to achieve this within the existing system will only lead to more burnout. Physicians are incredibly dedicated to their patients. However, at some point, the stress is untenable, leading some to retire prematurely, reducing their workloads, or even leaving medicine entirely. This loss of experienced and dedicated physicians will further exacerbate the situation for remaining doctors. Retention and recruitment of physicians is paramount, given 1 million Ontarians already don't have access to a family doctor. The lack of physicians is even more dire in Canada's north. Today, Northern Ontario is experiencing an acute shortage of at least 325 physicians, including family doctors, psychiatrists, anesthetists, and several subspecialists. Some communities are critically underserviced. The OMA's Burnout Task Force has identified the top 5 system-level actions required to reduce burnout and drive retention and recruitment. First, streamline and reduce required documentation and administrative work. Second, ensuring fair and equitable compensation for all work done. Third, increasing work-life balance by making organizational policy changes. Number 4, promote the seamless integration of digital health tools into physicians' workflows. And finally, providing institutional supports for physician wellness. These are all system issues. So we need to collectively and collaboratively rethink our healthcare system so that it doesn't contribute to burnout in the first place. In fact, in Ontario, we have developed a plan to solving our system challenges. OMA's Prescription for Ontario Doctors 5-Point Plan for Better Healthcare, released in October of 2021, so not long ago, and available at betterhealthcare.ca, provides a roadmap of 87 recommendations under 5 key themes to achieve meaningful and sustainable improvements for the entire healthcare system in terms of access, equity, efficiency, and integration. As contained in our prescription, the OMA strongly supports the call by Canada's premiers to immediately increase the Canada Health Transfer from the current 22% to 35% of provincial territorial healthcare spending. And this will provide the provinces and territories with the resources necessary to make health system improvements within their respective jurisdictions. Ontario's doctors also recommend other immediate actions by the federal government to reduce burnout and increase retention and recruitment, including but not limited to the following. First, incent physicians to practice in the North by offering a federal tax relief of 15%. Number 2, fund Canada Health Infoway to develop application programming interfaces, or APIs, to link the electronic medical record systems used within each province. Linking them would allow for information to be exchanged amongst physicians, and a lack of interoperability now is one of the most common digital health factors associated with burnout. And finally, supporting the development of virtual care appropriateness guidance by the national level specialty societies, who would work together to review all procedures within their profession and determine which can appropriately be done virtually or in person. Supporting the development of such guidelines reduces decision fatigue for physicians and supports equitable, appropriate, and high-quality care across the country. A publicly funded and universally accessible healthcare system is a cornerstone of Canadian values. On behalf of all Ontario healthcare professionals, the OMA implores the federal government to provide the tools and resources required by the province to effect sustainable and meaningful change. If we don't fix the healthcare system, we'll never fix burnout. And physicians and other healthcare professionals are depending on you, and certainly Canadians don't have time to wait. Thank you, merci beaucoup, and we're happy to answer your questions.
Thank you, Dr. Kassam. We're now going to begin rounds of questions with the Conservatives. Ms. Kramp-Nyman for 6 minutes, please.
Perfect, thank you. I'd like to, first of all, thank you, Chair, and thank all the witnesses that have agreed and so willingly volunteered their time and their expertise to contribute to today's discussions and the democracy of Canada. I'd like to start by directing my questions towards our witness, Dr. Pecora from Kingston. Before I get into the specific question, perhaps I'd like to allow me a few minutes to highlight that under his leadership, Kingston Health Sciences Centre has successfully brought together two of Canada's oldest operating hospitals. And Dr. Pecora serves, as he mentioned, as President, CEO of Kingston Health Services, an academic tertiary care centre serving people all across Ontario. He's a respected orthopedic surgeon, CEO and professor, a true pioneer in his field. So congratulations and thank you for all of your work you have done, Dr. Pecora. My first question today, could you perhaps speak to the complexity and the costs of hospital services? The physician shortage is most acutely appreciated in rural areas of our country, like my home riding of Hastings, Lennox, and Addington. The need for highly specialized individuals, it's never been higher. And further, if you could possibly elaborate on speaking to the interconnectedness of our healthcare system, along with mutual dependencies of hospitals and that of community services.
Well, thank you. I'll try to address your questions. Hospitals are very complex and highly integrated organisms, I would say. It's amazing the extent of just-in-time work we do with teams pulling together. Some of our surgical procedures would be just one example of what it takes to deliver this with highly specialized physicians, nurses, technicians who support various life support systems, et cetera. And we're the most expensive part of the healthcare system, so it's a valuable resource that we can't afford to waste any of it. We try to be very good stewards of the resources we receive, and having people is at the center of all of this. Everything we do requires people, and so having a robust and appropriately skilled healthcare workforce is critical, and so this is essential to our role in the system. And we don't just look inward. You talked about rural and remote neighborhoods, and although we're also the community hospital for the Kingston region, like many hospitals would be, but we provide extended services to a wide range, including dialysis services in your community. We have satellite dialysis centers in the Moose Factory General Hospital at Winnebago on James Bay, and that's just one example of the complex networks. Cancer care is another one. It's a very distributed system, and although we may be the hub for a lot of these activities, and the place where the most complex required care comes, we support services throughout the region. I think one really good example of this would be the Ontario Stroke Network, which has become a highly effective and life-changing network for patients that in the past had a very dismal prognosis in many cases. And now, because of rapid diagnosis, rapid transportation, and rapid intervention, we're able to reverse the life-changing effects of strokes and really give people a much brighter outlook. So that's kind of an example of the complexity and the expense of running a healthcare system and the role of hospitals. In terms of interconnectedness, most hospitals are experiencing gridlock at the moment. We certainly are. And this is because of increased inflow pressures to our emergency department with patients that are highly complex and critically ill, and then outflow pressures related to home and community care and long-term care, just two examples. And so, we've heard people talk about the HHR challenges of other sectors of the healthcare system, and that is having a big effect on hospitals too. So we can't just focus on one element in isolation, and we have to have a system-wide look at this. Thank you.
Excellent. Thank you.
And if you want it, Ms. Grimp-Nyman.
So perhaps I'll continue on. We have 1 minute left, Dr. Pecora. So perhaps, and if you could speak directly to, we have shortages. We have there's a lot of fatigue. Our healthcare system was tired before the pandemic, and perhaps it certainly, well, not perhaps, it has been highlighted now by the pandemic. How do you see, there's no quick fix, you're not a magician, but a way out of this? Is there one or two key points that you could speak to that you see?
Well, you're right, there is no quick fix. But, right now, the thing that's impeding our ability to restore care most significantly is our rising ALC rates. The patients who've completed their journey of care in the hospital and they're waiting to go to another destination, whether that's home and community care, rehabilitation, or long-term care. And that would make the biggest difference in the short term to us, is to try to implement remedies that will boost capacity in the community so that a hospital can do what it's supposed to do.
Thank you, Dr.
Fantastic.
Gore.
Thank you.
Thank you, Ms. Grant-Nyman. Next, Mr. Van Couverden, please, for 6 minutes.
Thank you very much, Mr. Chair. And before I start, I'd just like to send a huge thank you out to every witness today. You represent the people, the workers that have been supporting our communities through the toughest time that any of us have ever lived through. You truly are the frontline infantry people of our system, and while it is very, very challenging work, Canadians are grateful. And, you know, Canada's fared fairly well compared to many of our peer nations, and that's because of your hard work and because of the hard work of your members. So we can't thank you enough. Apologies for that. I have a couple of questions. I suppose my first question will be directed to either the Canadian Medical Association or the Canadian Nurses Association, or I suppose it's the Ontario Medical Association, sorry. I was just looking over some of the data provided to us from the Library of Parliament, and I always like to see where Canada ranks internationally among some of our peer countries. I used to be an athlete, and it was always good to see where you at compared to your kind of competition. Not to suggest healthcare is a competition, but it is nice to see where we rank. And we all know that there aren't enough doctors or nurses in Canada, but it's good to know whether they're on the rise or on going the opposite direction. What the data indicates is that it has been on the rise, just not quickly enough, and it hasn't kept up to our population, and it probably wasn't even adequate 20 years ago either. So it's clear that, and I think we all agree, that we need to increase the workforce. That's sort of an obvious statement, I suppose. But the next question is how. I spoke with a constituent today who is a neighbor and a good friend. She's a personal support care worker, and she would like to become a nurse. And we were discussing how she can go about that. She has 2 kids, so it's going to be challenging financially for her. But from the Canadian Nurses Association perspective, how can Carly, find the support that's necessary to go from the work that she's doing now and join the workforce as a nurse? And if you could perhaps touch on the impact that immigration can play and foreign credentials qualifications might play in ensuring that we have the workforce necessary to continue on.
Thank you very much, Mr. Chair, for the question. Certainly, there has been a move over many, many years for nurses, and there are 4 regulated categories, and then there's an unregulated group of support workers, I'll just use the general term, who sometimes want to move from one level of nursing or one type of nursing to another. And one of the areas that we haven't made it easy historically is in how you move, for example, from being a support worker to a licensed practical nurse to a registered nurse and so on. There are some bridging programs now which are better, more of them, and better than they used to be. One of the things that we haven't done as well historically in nursing is that you almost had to start over at each level when you went into a program. So it was a bit discouraging for people who might have been at the top of their game at the age of 35 in one category, wanting to go back and move to another. So that's been a bit of an issue, but it is being addressed. In terms of internationally educated nurses, there are other health professionals, of course. There are certainly many we hear across the country who find that the rigors of getting through the regulatory process is quite difficult. I'll give you an example that I spoke with a young man from Tunis just last week who has a PhD from one of our very good universities and is really struggling to get through the regulatory process to get registered in this country, to the point where he's saying, I think I'm just going to go back rather than go through it. So we believe that there could be some moves made to help smooth those processes to get people in faster. And I know that regulators are trying to do that, but I think there's a way to go, Mr. Chair, to answer that. And one of the areas I'll close by saying is language. Often these nurses come from very good universities in other countries, they're very well educated, but they have trouble with the language test. And yet when I talk to them, I can understand them quite well. So I think that we together need to look at all those sort of hoops that seem to get in the way of bringing people into the healthcare system when they're interested in working or in moving up. I'll end it there. Thank you.
Thank you, Mr. Villeneuve. Mr. Chair, I tried to start a timer at the beginning and I started an alarm anyway. Could you give me a 1-minute warning when I'm almost at my time? I would pose the same question to Dr. Kassam, a fellow Adam at the Ontario Medical Association, if you can provide some insight.
Absolutely, and thank you for the question. It's an important one. As far as health human resources are concerned, and obviously just in the of what we said earlier, 1 million people in the province of Ontario don't have access to a family doctor. We expect immigration and population growth in the province. We also expect and are seeing an aging population that will invariably require more healthcare utilization. So it's not only a combination of a growing population, but a population that's going to require more healthcare services, down the line. And so, how do we address this? Well, as you said, Adam, member, we need more doctors. It's very clear that we have a physician shortage, and we've had this chronically for quite some time. But how do you do that in an effective way? First, you got to stop the bleeding, make sure that we can shore up what we have right now. So making sure that physicians don't leave either the province or the country or the profession.
Thank you, Dr. Kassam. I'm sorry, I've got to cut you off because I have to do a motion. And if the committee will indulge me, that pursuant to Standing Order 1082, the committee invites the Minister of Health, the Minister of Mental Health and Addictions, and Associate Minister of Health, as well as officials, to appear for 2 hours regarding the 2021-2022 supplementary estimates, the 2022-2023 main estimates, and the 2022-2023 departmental plans for the Department of Health, the Canadian Food Inspection Agency, and the Canadian Institutes of Health Research, and the Public Health Agency of Canada, and that the meeting take place on Monday, March 21st, 2022. Sorry, Dr. Kassam, that was rude. I apologize. I have to get too much done in 6 minutes.
No problem
Okay.
at all. I totally understand.
Colleagues, this is the motion that was put on notice at Monday's meeting. The motion is in order. The debate is on the motion. Mr. Barrett, please.
Yeah, so thanks very much, Chair. Through you to Mr. Vancouver, and I guess it would be helpful to know if we're going to have ministers and officials for the combined total amount of time. Sometimes they split an hour and an hour, and also, multiple ministers and multiple officials over a 2-hour period can be can be a bit of a tight time frame. If there's any leniency on the amount of time that the ministers are available, though I of course note that we appreciate that the ministers are making themselves available to be at the committee.
Mr. Vancouverton?
Thank you, Mr. Barrett. If you have a preference or if you have a recommendation, I think the benefit of having 3 weeks is that potentially the Minister, particularly of Health, will have the time. I believe on that date, the Minister of Mental Health and Addictions only has minimal lines on the estimates. They're not entirely complete, but the Minister of Health will have complete lines. So I think we'll have, you're right, there will be a lot of people at the meeting. But if you would prefer to have a different balance of officials and ministers, then we have the time to discuss it, and I have the time to go and advocate for it with the ministers.
Barrett?
Okay, thank you, Chair, and thank you, Mr. Vancouverton. Having the ministers available for the full 2 hours is important, that we're not hiving off the officials. I mean, but it's important that we also have the opportunity to ask the officials questions. So having the ministers available for 2 hours and the officials for an additional hour, I mean, yes, I instinctually I would like to ask for the ministers to be here for 3 hours. I have lots of questions for both. But just if we can focus on the ministers for 2 hours with the members can use the time as they see fit and also ask the officials questions. I appreciate their time is also valuable, but a little less harder to pin their schedules down than ministers. So my suggestion through you, Chair, is that it would be 3 hours for the officials and a total of 2 hours that the ministers would be available to the committee.
So thank you, Mr. Barrett, and through you, Mr. Chair. Are you asking that this be covered over 2 meetings, over 2 Mondays? As the COVID meetings are on Mondays, or are we asking for a 3-hour meeting? Just so I'm clear. I mean, I think we can ask if the officials could come concurrent with the ministers on the first Monday, which is the 21st, and then maybe just the officials for a subsequent hour on the following Monday? Or a 3-hour meeting?
And just, so thank you, Chair, and thank you, Mr. Vancouver. And yeah, and I guess following the completion of the first meeting, then the committee we could discuss if the officials were required the following Monday, because resources are difficult to come by. So just tacking on a third hour, especially if we get jammed with votes or anything like that, might be tough. So I guess potentially it would be, if there's a willingness to extend questioning of officials on the following Monday if required, but just with the baseline that the ministers will both be available for the 2 hours on the at the meeting for that's in the motion that you've moved.
Okay, yes. The ministers will be present for 2 hours, and I will ask about a third hour for the officials. Yeah. And for clarity, I think I said this would be a COVID meeting, and I think it's separate, although it is occurring on a Monday. But, yeah.
So just from a procedural perspective, if I may, Mr. Barrett, the motion does indicate that the ministers would be here for 2 hours. I would suggest if at the end of 2 hours there's a willingness to bring back officials for a subsequent meeting, that a motion could possibly be presented at that time, if you think that would be required. Is that okay procedurally?
Yeah. So based on that assurance that the ministers are available for the 2 hours, and based on your comments, Chair, then I have no objection or further questions.
Okay. Thank you, Mr. Lake.
Just a question, what is our deadline for reporting this back? When do we have to complete this by?
There's a different deadline for sub-Cs than there is for mains. Sub-Cs is... Oh, okay. It as you know, it depends on when the last allocated day is. So we still don't know the deadline for sub-Cs, but we do know that it's much longer for the mains. But because all of the days have not yet been allocated, the firm date for the deadline is at this point unknown.
In the spirit of this, Mr. Barrett's suggestion, then, regardless of when that deadline is, if we decide we want to have officials come, we would have them anyway.
Yes, the committee is at liberty to study the estimates even when the time is up. They just can't vote on them. It would become a subject matter study. So
we're on the record right now, and I just want to make sure that from Adam that would be the spirit of what we're talking about.
Yeah. Okay. Any further debate on the motion? Are we ready for the question? Okay. You have the motion before you. Can we proceed by consensus, or is there a requirement for a standing vote? Okay, is it the will of the committee to adopt the motion as presented? I see consensus in the room. Thank you. The motion is adopted. Next, we're going to go back to our questions for the witnesses. Et le prochain député à poser des questions, c'est Monsieur Thériault.
The next member is Mr. Thériault.
Merci, Monsieur le Président.
Thank you, Mr. Chairman. I'd like to start by thanking the witnesses for their very informative testimony. There's not much time in 6 minutes here to go through too many questions and answers, but I'd like to start by Mr. Villeneuve. In a document that was circulated, I see that there should be a shortage of 60,000 nurses by 2022. I think this is the year 2022. So you're saying that was already predicted 10 years ago. So it begs the question, at that time, what were the determinants that allowed you to say that?
Il y a 10 ans.
So 10 years ago.
Thank you, Mr. Chair. If with permission, may I turn this to Dr. Tomlin Murphy, who led the study?
Thank you. And thank you, Mr. Chair. Thank you for this opportunity. It was quite clear when that study happened some time ago that there were similar issues that there are today. And if we go a decade before that, there were similar issues at that time. So if you think about the study, what we focused on were, what are the health needs?
Mais pourriez-vous les nommer?
Could you name them, actually? Could you go through them these issues, please?
Yes. So the issues at the time is that we focused largely in this country on increasing seats, nursing seats, for instance, medical seats, for instance, without really thinking about what other strategies could be in place. That is, how do we actually retain the workforce who was already there? Retention at that time and strategies that are still pertinent today are finding ways to actually value the workers, to actually have staffing ratios and to have staffing patterns in place that services can be delivered to Canadians that match their needs. And also during that time, it was clear that what we hadn't talked about was how providers actually work together as teams, wrapping around the needs of Canadians. And that looks very different depending on the context. You all understand that. But it also depends on the context in which care is being delivered. So how can one say that you need to increase a certain number of training seats, for instance, without thinking about the impact of technology and efficiencies in the system, without thinking about when we work as teams, regulated as well as unregulated workers, to address the needs of Canadians, that there are other alternatives. So during that study and the strategies, I think, to the question that were important, that if we did nothing at all, that we would see a shortfall, that is a shortfall between what Canadians actually needed in terms of health needs, as well as the supply to deliver the services. So it's both components, needs as well as in requirements for care, as well as supply. So if we did nothing, we would have seen a gap of 60,000 predicted in 2022. If we put in strategies in place, things like dealt with attrition rates in universities, supported students using principles of equity, diversity, inclusiveness, as well as other supports like incenting students, supporting them during employment, and looking at other things. If we did that on its own, it would have helped to reduce the actual gap. But if we add to that, if we looked at strategies, for instance, to keep nurses working, that is physically well, mentally well, that would have helped to have reduced the gap. But living through COVID, as an example, we have not necessarily dealt with, and we have seen the light shone on, the mental health problems, issues that continue to be in the way for nurses, as well as finding a deterioration in physical health through exhaustion, through heavy lifting, and working oftentimes very, very short.
Excuse me. Yes. So what I was perhaps more concerned about, or what I was asking myself questions about, was this. So what happened 10 years ago, well before the pandemic started? What led to this problem? Anyhow, is this issue, the issue of private agencies, for instance? In Quebec, for instance, you have nurses that are leaving public healthcare systems to go towards these private agencies because on some level there'd be better control over their working conditions and their schedules. Is this phenomenon not actually some indication of the problems inherent in these public systems today? And based on that, would it be possible to reorganize things based on these conditions that these nurses are facing? When they're getting to these agencies, they get better conditions.
So,
go ahead, Gail.
Mr. Chair, what I would like to say is we know that healthcare is a federal, but also a provincial territorial issue. And so if we look across this country, and what the Royal Society Canada paper has demonstrated is that some of the provinces and territories are taking on innovation and investing in innovation different from others. If I speak to the question that you have asked, overall, this is not a phenomena that was just came to play 10 years ago. And the work that I do globally tells me that the time that we pay attention to shortages and gaps in the health workforce is when there is a crisis of some kind. And when there's not a crisis, which can be fiscal in nature, it can be a pandemic, or it can be a surge or a threat. When those critical points are not in place, then governments across this country oftentimes relax and become quite complacent with putting strategies in place to address the workforce. Okay. So the example that you have provided, COVID has helped us to appreciate that indeed, oftentimes we need to think about alternative arrangements and options to ensure that Canadians and across this country are receiving care.
Okay.
So during COVID.
Okay. Thank you, Dr. Tomlin-Murphy. Next, Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair. Thank you to all the witnesses for being with us. Ms. Vance, I want to start with you, please. We know that we have a problem with access to primary care in Canada, and I think we all recognize that historically the family doctor has been considered the first point of contact, and I think that's giving way to a more modern notion of better utilization of a team-based approach to healthcare. And I think you touched on that in terms of the role of pharmacists and how better use of pharmacists and their expertise as one allied health professional may actually relieve pressure on the family physician. I think the example you gave was by perhaps allowing pharmacists to provide prescriptions for common, easily diagnosed ailments. I wonder if you could expand on that. I'm curious about whether that could extend to things like prescription renewals or maybe injections. I know pharmacists have played an important role in the COVID. So what other things could pharmacists do that might take some of the pressure off the family doctor and provide quicker access to care for patients?
Thank you very much for the question. And I will apologize to the interpreters from earlier being plus vite, bad French, but there you go. I think if we look across the country, that Alberta really has set the stage for demonstrating what pharmacists can and should be doing in terms of primary care. And as I noted it in my remarks, the Canadians are anxious to interact with their pharmacists and get more care from their pharmacists. So they're not the barrier in any way. And in Alberta, where there are prescribing rights, and in Saskatchewan and in Nova Scotia and in Manitoba and pretty much across the country, including the Yukon, recently given some authority during COVID for what is categorized as minor ailments or self-identifiable. So whether it's shingles, and if I may, I will use a very personal example. I got shingles about 6 months ago. My primary care physician has not been in their office since March 2020. I had a call with my physician on the phone, and it was I who identified that they were shingles. And I went to the pharmacist who looked at the medication that had been prescribed and intervened with my physician to get a different medication. I showed my pharmacist where the shingles were, thankfully, and not too difficult to spot. So pharmacists deal every day with their patients. And I think no one in this country would disagree that we need more support for doctors and for nurses. Absolutely. But we are missing a huge opportunity by not better employing community pharmacists who are in communities who, as the stats from 2018 show, see their patients as much as 10 times more than they would see their family doctor. So I think it's really, as we look ahead at the solutions, we need to ensure that we are looking at employing the resources that we have in addition to augmenting those that exist.
Where my mind is going, and I'll give my own little personal example. I've been on medication for a long period of time, and I have to get a renewal about every 6 months. This has happened probably 25 times, and I have to go back to my doctor for the renewal on something that is automatic. I know I'm automatically going to get. Is that something that would be just as easily, or maybe even better, handled by a pharmacist?
Yes, absolutely. And in British Columbia, we have adaptation and renewal rights, and our college, in fact, is looking at expanding those at this time. And throughout the pandemic, for 2 years, many patients were getting their prescriptions renewed by their physician over a telephone call. So I think the notion of saying that patients with stable conditions, whose medications do not vary from time over a period of time, should not have those easily renewed at the pharmacy. That case can no longer be made. That frees up family physicians to see patients in person that really need their care. And I think, again, it's about better utilizing pharmacists to ensure that family physicians have the time to spend with those patients that need to see them.
Well, and I mentioned the economics of it too.
Yes.
Could you give a comparison, or is that possible, between what the cost would be of me going to my doctor for my prescription renewal versus me going to the pharmacist and the dispensing fee or whatever it would cost?
So if you were to do an adaptation, if a pharmacist were to renew your prescription, we are talking about a $15 fee. In British Columbia, if a patient to go for a basic 0100 family physician visit, that's in the neighborhood of somewhere between $40 to about $65. So certainly economically, the numbers are there, which would allow for redeployment of those resources to do other things.
Now, Ms. Vance, I want to put some data collected by the Canadian Institute of Health Information to you. It says the number of pharmacy graduates in Canada dropped from, I'm rounding off, 1,300 in 2016 to 1,256 in 2019 and 1,255 in 2020, while the number of pharmacists in Canada increased over that period from 34,000 to 44,000. And when I looked a little further, the data also showed that in 2020, international graduates accounted for 34% of the overall supply of pharmacists. What can you tell this committee about where Canada is getting our pharmacists from? And it seems to be a bit of a success story in terms of our ability to attract foreign trained pharmacists and get them working in this country, which is not necessarily the case for other professions. What can you tell us about
absolutely. I think in the way that saw 20 years ago or 30 years ago how dependent Canada was on foreign trained physicians that came from places like England and Scotland and Ireland. We're seeing pharmacists come from around the world. Canada is a good place to practice pharmacy. And so we are certainly seeing them easily integrated into the care that they provide in communities and also in hospitals. So I think it does serve as a demonstration for what is potentially possible in the other professions.
Thank you.
Thank you, Ms. Vance. Thank you, Mr. Davies.
Thank you.
Next, Dr. Ellis, please, for 5 minutes.
Just a point of order, Chair.
Yep. Mr. Barrett?
It looks like the vote call will be in just about 4 minutes, and so that'd interrupt Mr. Ellis's time, and I'm just wondering if...
This would be a good spot to suspend until we've completed voting. Just to the witnesses, there's a vote happening in the House now. We do have a capability of voting on our phones, but we'll need to suspend to ensure that that happens, so we'll be back to you in about 10 minutes. The meeting is suspended. to order. Thanks for your patience, witnesses. We're going to resume rounds of questioning, and I recognize Dr. Ellis, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for your patience. I hope you enjoy seeing democracy in action here. That's the best part of it all. I had a question for Ms. Vance, if I could. You talked about trying to ensure that there was some sort of conformity across Canada with respect to skills that pharmacists might use. Would that also include something like a pan-Canadian license?
Hard for me to speak to regulatory issues, but I think not like it's dissimilar with physicians. There's a skill set that is applicable regardless of the province in which you, or a nurse in which you practice, that you need to meet provincial regulatory requirements, but there's a commonly accepted set of practice expertise, and so that's what we're looking for. If you look at, prescribing rights, as I said, for across the board in Alberta, having the most, the broadest use of pharmacists in the province, and other provinces like Nova Scotia allowing for prescribing of this and that, and different provinces and different things. So we're thinking that a standard scope of practice would be a good place to start.
Great. Thank you very much for that. I appreciate it. Dr. Kassam, if I might, we talked a little bit about some of the solutions, and of course, the OMA has presented a very comprehensive picture of that. I'm just wondering about the short-term look at recruiting physicians, and it would appear that perhaps, if I did my math right, we're around 500 short in Ontario. How might we change that in a very, very, very short term? One or two or three things you might think of.
Yeah, thanks for the question, Dr. Ellis. And it's a very important question as far as health human resources are concerned. The first thing that we need to do is stop the exodus in the profession. So shoring up what healthcare resources that we have right now as far as physicians spread across the province. As far as what we can do immediately, we can fund more medical student spots as well as residency spots. It makes no sense to have an increase in medical enrollment that is not followed commensurate by residency training spots. That just creates a worsening of a problem. And then finally, of course, we need to align incentives in a variety of regions. To be very frank, in northern and rural parts of our province, we have trouble retaining and frankly recruiting physicians. So aligning incentives, whether that means financial, supportive infrastructure and innovation incentives, these are sort of areas that we believe would actually serve a purpose as far as retaining and recruitment in areas that are underserviced.
Thank you, Dr. Kassam. One other question: has the topic of pensions for physicians come up, and what does the OMA think of that?
This is an important issue because, as most people on this call and in this committee know, physicians have to self-fund their pensions. Unlike other public servants unlike other public service workers, there is no pension for physicians. This is a huge problem for our profession broadly. It also is a challenge as we think about the future for the profession as far as being able to care for them and their families into old age. And so the pension issue is a very live one. It's one that the physician community is very strongly in favor of, and it requires, I think, attention both at a federal and a provincial level to really move that ball down the field.
Thank you, Dr. Kassam. Dr. Tomlin Murphy, if I might, we have some numbers here from the OECD, perhaps 8.8 nurses per thousand population. In Canada, we're around 10 per thousand. Can you tell us a bit about why there might be a discrepancy there in the number of nurses that we have, which would be above the OECD average?
Thank you for the question. And Mr. Chair, what I would like to say at this point is when we do comparisons around between OECD countries by numbers, if you look at a number of somebody by population, I think that only gives us one picture. What it doesn't give us is what the needs of the population are, or the care and the care delivery system in which nurses as well as others are actually participating. So I think in terms of the OECD comparisons, they're helpful. I think the better comparator is for us to look more closely across this country by provinces and territories and better understand that. I think in terms of OECD, we probably are ranking pretty well, but we need to be thinking more than numbers per population as we look at any provider group.
And just one quick question, Dr. Tomlin Murphy. In Nova Scotia, how many nurses do you think we're short, since it's our home province?
Thank you, and thank you so much. And if we look across the province, we are looking at high vacancy rates. We are looking at somewhere, Nova Scotia Health, a provincial health authority, as you're aware, about 800 vacancies right now, as we are already working short. So we do have very many good strategies in place that we are feeling very optimistic about. Strategies that have to do with hiring students, for instance, during their programs, which gives students a sense of value and becoming part of a healthcare system early, as opposed to time of graduation. We also are looking at ways that we can actually precept and mentor nurses much differently, and that is by using the retired pool, for instance, of nurses who have lots to offer. As you're very well aware, we also are looking at strategies to look at ways to actually better prepare to receive internationally educated nurses by taking it very seriously in terms of preparing in the province, as well as I think across this country we need to, so that we can successfully integrate these workers in a timely way, in a way that recognizes their credentials and move them into our healthcare system delivery as bridge programs from CCAs to LPNs, NPs, and others.
Thank you, Dr. Tomlin Murphy. Next, Dr. Hanley, please, for 5 minutes.
Thanks, and I'd like to add my gratitude to all of you for having appeared and given your time, especially in a somewhat interrupted way this afternoon. So many questions, so little time. I'm going to perhaps start with Dr. Kassam. And I think you mentioned credentialing along in your opening remarks, and I wondered if you could give me your views on how we could be more efficient in international credentialing. I don't know why I can't say that word today, and also maybe comment on the question about pan-Canadian licensure and whether you would see that as an advantage.
Yeah, sure. Thank you so much for the question, Dr. Hanley. And given your expertise in the area, I know that this is sort of something that's germane to not only your understanding, but also the understanding of the committee. Obviously, we have or at least perhaps we need to have an international strategy for health human resource recruitment, and that will invariably include a pathway to credentialing. And now this is obviously a very complex situation because it requires multiple institutions, including the Royal College of Canada, Royal College of Physicians and Surgeons, the Canadian College of Family Practice, as well as the provincial colleges of physicians and surgeons. And so this is a multilateral approach that will have to be undertaken, but invariably this will have to also relate to what we are very deeply committed to here in this country, which is quality of care, not necessarily quantity of care, quality of care. So how do you ensure a minimum quality of care and competence from places around the world so that Canadians can continue to receive the best and frankly highest quality of care that they deserve and need? And so this is also a challenge in that space. And there needs to be a strategy for onboarding, whether that means apprenticeship programs, whether that means perhaps even a more streamlined approach into being able to stand for and frankly challenge the board examinations that are of course necessary in order to proceed through licensing. These are conversations that need to happen at a federal level, and this is where you and your colleagues have a great role to play.
Thank you very much. A question for Dr. Pecora. Fascinating opening remarks. Thank you very much for all your work and your vision. I'm wondering what a post-pandemic hospital looks like, or could or should look like, versus a pre-pandemic hospital. In other words, what have you learned in the experiences of what you can do, what you can maybe not need to be involved in? What are the efficiencies? Maybe give a quick synopsis on that.
Well, apart from the fact that everything has changed, it's a little hard to give you one or two examples. We're learning how and where digital and virtual care is most effective. It's not useful everywhere, but it's highly useful in selected places. And we've got a lot to learn about how to integrate virtual care into, our traditional and future planning of how we would deliver care. We need to, just like we've been talking about maximizing the scope of practice for various healthcare workers. The Americans talk about practicing at the top of your license. We need to do the same thing in hospitals. You know, we have our main site is a highly intense critical care site. It's the trauma unit, cardiac surgery, neurosurgery. Our Hotel Dieu site is an ambulatory site where we deliver day surgery and short stay surgery and highly effective hip and knee replacement, cataracts, and bariatric surgery. So we need to have those sort of strategies. And how do we build out the ambulatory system? We've learned that we have to partner a lot more effectively across the healthcare system in every way. And we're certainly, for example, working with an independent health facility around assisting in delivering our cataract volumes. I can see the potential to do more of that as we get better integrated and more effective and efficient at doing it. Distributed networks. We're spending a lot of time assisting other hospitals, larger and smaller, and there needs to be more of that as well. So, you know, those are just a few examples of many things that have changed. And so there's some things we need to restore from the past. There's some things we need to continue doing that we've learned in COVID. And there's other opportunities that are yet to be developed.
Mr. Chair, do I have any more time?
About 20 seconds.
20 seconds. Mr. Villeneuve, rural versus urban in 15 seconds.
Need more nurses in rural. Our balance is...
Well done, and thank you. Suite, Monsieur Thériault, pour 2 minutes.
Mr. Thériault, you have 2.5 minutes. A short 2.5 minutes. Dr. Kassam, I appreciated the fact that your association has managed to verbalize the fact that it agrees with the provinces and Quebec as to the chronic underfunding that has been going on for so long, and that your association supports an increased transfer by 30%, healthcare transfer. That's 28 billion, 6 billion extra dollars for Quebec. I haven't done the calculations for Ontario. What would you do? Let's say you got an extra $6 billion in Ontario. I like the fact that you iterated these needs you have. What would you do with an extra $6 billion?
Well, I wish I had $6 billion in my bank account, but that would be a lovely dream to be able to have. But as far as where we think investment is required, we obviously think about the backlog of service that has unfortunately expanded during COVID that now exists to a shocking number of 21 million healthcare services in the province of Ontario. It's probably much larger across the country. So getting through that backlog of care and reducing wait times is key priority number one. Number two, investment in mental health and addiction services. We know that over the past year, the 2 years that we've had with COVID, we've seen an escalation in, unfortunately, opioid-related deaths and overdose deaths as a result of the exacerbation of COVID and the pandemic on these populations. So investment in mental health and addiction services is number three. Number two, the third is trying to make community care, home care, and retirement and long-term care more robust. That would be a third area of investment. And then finally, the pandemic proofing our future. So investing in public health to make sure that to ensure, frankly, that we are better prepared for the next one.
J'aime bien.
I like your answer, because a number of people have just told us that what's required to get through this situation we're in with these networks now is dedicated funding, because people that are working here would not be able to supposedly identify the priorities because they wouldn't know what to do with the increase in healthcare transfer. I'm happy to hear what you have to say. 502,000 some people that are waiting for services. What is that due to, this backlog?
Well, unfortunately, we know that smaller problems become larger problems. People have been waiting for a variety of different care, whether it's primary mental health and psychiatric services. It could also, of course, extend to screenings of colonoscopy and mammograms for cancer screening, for example. It also extends to procedures and surgeries that people have been waiting for, whether it's hip or knee replacement, whether it's a cataract surgery, whether it's a cancer removal surgery, for example. And so this runs the gamut of our healthcare system. And so what we have found over the past 21 months within this pandemic, we have unfortunately seen an escalation in terms of late presentations of pathology, which means that, advanced stages of disease, which of course have perhaps worse prognoses. And also, when we think about a system level perspective, this actually costs more to deal with. And so we know that the pandemic has had a significant impact on the ability to not only provide service, but provide service in a timely way. And this is now our task as a country to think about the future.
Thank you, Dr. Kassam. Mr. Thériault. Next, Mr. Davies, please, for 2.5 minutes.
Thank you. Ms. Tomlin-Murphy, do you have any general idea how many foreign-trained nurses there are in Canada right now who are unable to practice because their credentials aren't recognized? Ballpark?
Mr. Chair, I actually wouldn't have that number. I would defer to Michael Villeneuve on that number.
Sure. Mr. Villeneuve?
Thank you, Mr. Chair. We don't know the exact number. You know, we hear sort of anecdotal reports across the country of that there are many in the pipeline waiting to get in. But I can look that up for you and be happy to report it back. There is about 9% of the nursing workforce that's internationally educated, if that's of any help. But that's been a long-standing pattern of individual migration.
Yeah, I mean, we know that it's a problem, for instance, with foreign-trained doctors. I know have a really hard time getting credentialed in Canada. I mean, can you give us a sense for whether that is, like, how serious of an issue, if at all, it is with respect to nurses in the country?
So I can...
Yeah. Go ahead, Gail.
Okay, I can answer that, Mr. Chair. So in terms of what we have learned, is that we haven't done a very good job. There are some provinces and territories who have taken this seriously, definitely, as well as federal government, to find ways that we can actually spend more time with our workers prior to coming to Canada. So innovative ways, for instance, working at the country level, offering, for instance, distance type of learning, English while in country, moving towards the credentialing opportunity while in country. So we also have found that some of the innovation here is actually preparing communities, whether it's for children in school, for it's the employers, businesses, universities and colleges and local businesses.
I'm getting
prepared.
Get one question in, if I can, to Dr. Kassam. Dr. Kassam, the OECD provides a breakdown of various categories. They say that Canada had the second highest proportion of generalists in 2019, but was below the OECD average for the proportion of specialists. I'm interested if that's your experience, that we're having difficulty getting specialists, and if so, what categories of specialists are most needed in Canada? Where is the deficiency for retention and recruitment most acute?
So I think it's a hard question to answer because it really is highly regionalized. So you might not need a dermatologist in downtown Toronto, but you might need one in Northern Ontario. So it really is matching supply and demand and need with the appropriate service to be provided. And we don't, but generally speaking, we have a very good understanding that there is a broad shortage of both family doctors, primary care, and specialists in northern and rural communities, at least as it pertains to Ontario. And this is why we need not only an urban and suburban, health human resource strategy, but we also need a rural and northern strategy as well.
Thank you, Dr. Kassam. And Mr. Davies. Next, Dr. Ellis, please, for 5 minutes.
Thank you, Mr. Chair. And if I might, Dr. Pecora, an interesting question perhaps to start. You talked about doubling your ICU capacity during the pandemic. How were you able to do that?
Well, in the early phases of the pandemic, as you know, emergency departments really closed down. People stopped coming. And there was lots of capacity in regional hospitals, our local post-acute care hospital, rehab, and bed types. And there was capacity in long-term care. Now, you can argue in the end whether it was a good idea to move so many patients into long-term care in the province because of the consequences. But nevertheless, that happened. And so hospitals had a lot of empty beds. Our occupancy was the lowest it's ever been. Our ALC rate was the lowest it's ever been. So we were able to redeploy staff and reconfigure facilities and bring in additional monitoring and ventilator equipment to create additional ICU beds. But for every one of those beds we created, we had to close 5 acute care beds. Now, fortunately, those beds were empty at the time, and we had to redeploy the nurses and other healthcare workers that were staffing those beds. And so we were able to do that last spring. We could not do that today because of staffing shortages. The hospital is full. We've got the highest number of ALC patients we've had in 2 years. We've got about 100 nurses off today with COVID-related, either they're infected or family members, their kids are infected. And so the ability to ramp up that level, we're still running on more ICU beds than we ever ran before the pandemic. But to get back to that double rate that we were in May and June, we would not be able to do that today.
And Dr. Pecora, is it fair to say that your hospitals generally run at 95, 96, 100, 130% capacity as we do in Nova Scotia?
Most Ontario hospitals run in those ranges, yeah.
Okay. Dr. Pecora, a couple other questions. You talked about maximizing scope of practitioners. Do you think that will require alternate payment schemes for physicians?
Well, that's one of the options. I mean, we do have an alternate payment plan here at Queen's, which has protected physicians from the ebbs and flows of ability to bill fee for service during the pandemic. With the nursing shortages and others, we've hired and trained a lot of nurses, as many as we could. But as you've heard, the prospects of hiring and replacing all of those nursing vacancies in the next few years that's a daunting challenge. So we've been hiring extenders and trying to train new classes of workers to support our nurses. OR techs to support the OR nurses, for example, mobility aides who can get up and get patients walking so that the nurses can, again, practice at the top of their scope. So we've done a lot of that to extend the capability of our existing staff while we continue to try to hire regulated staff.
And Dr. Pecora, we've talked a bit about virtual care, and certainly, there are issues around virtual care of how it's done and which cases you should choose, and that doesn't take into account internet and et cetera, all those types of difficulties and perhaps difficulties that elderly people may have in using the technology. What kind of challenges do you see on a regular basis? We heard from Ms. Vance. She talked to her doctor on the phone, which, of course, for diagnosis of shingles is not helpful. I find those examples are hard to take as a physician. So, what do you think we should do about that?
Yeah, it's complicated. Because there are opportunities, in my own domain, doing certain follow-up visits by virtual care, telephone can be quite effective and save patients from having to travel long distances. On the other hand, doing consultations and providing urgent and emergent care in orthopedics and many other specialties requires hands-on care. So I think we have to find the balance. It's not all or none. And I think what we've found is that and Dr. Kassam could probably speak to this better than me, but because of the nature of family practice and the size of the offices, the size of the waiting rooms and the staff and availability of PPE, they really had to resort to telephone care and virtual care more than any of them would want to do that. And as a consequence, I think that has contributed to building the backlog of patients needing referral. And certainly, in our own setting, in our orthopedic practice, the new referrals to my colleagues fell like a stone during the first few stages of the pandemic. And it's starting to come back now as care is returning to the office setting. And so I think that's something we need to learn from.
Thank you, Dr. Pecora and Dr. Ellis. Next, Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all our witnesses. My question is going to go to the CNA, both to Mr. Villeneuve and Madam Murphy. Welcome to our committee. It's good to see you both once again. In your advocacy, in the documents you provided, you've noted that the crisis requires a multi-pronged solution. Can you kindly elaborate on this and define what factors play into the solution that you're recommending from a short-term to medium and long-term?
I think I'll start. Thank you very much, Mr. Chair. So there's a couple of issues at play, dynamics. One is that different waves of COVID have really impacted different sectors. We know the terrible outcomes that happened in long-term care, for example, in the first wave. We've just heard Dr. Pecora talk about critical care. And in the third wave, critical care was pretty badly hit. Maybe it's the fourth wave. I'm losing track of the waves at this point. But so we really hit long-term care. We really stressed critical care. And this last one has really pushed all the buttons in med-surg units, in general hospital units. Still some people going into ICUs, but hospitals are full. So we have three major sectors of the healthcare system that have really impacted nursing. And at the same time, older folks like myself who might have been lured into staying a bit longer before retiring are saying, I can't do it anymore. So that their retirement phase, which might have been 5 years or something, is being compressed now because of the COVID experience. And we see them saying they're going to leave the profession. But the Canadian Federation of Nurses Union study showed us that in most recent polling, it was the nurses at the beginning of career and mid-career that were going to leave, that wanted to leave or intended to turn over. So you hit three big sectors. You hit new career, mid-career, late career nurses, and we're in a pickle. So the things that are going to help retain a nurse, for example, who's 63, are very different from a nurse who's 25. That 25-year-old nurse might be delighted to stay for a return of service if the debt was cleared, the student debt, for example. Well, that's not going to make a difference to the nurse who's in their 60s. So that's the kind of thing we mean, Mr. Chair, when we talk about a need to look at a very multifaceted approach to how we're going to treat the problems, not just the problem.
Madam Murphy, any comments before I ask the next question?
Thank you. I would agree 100% with Michael. And I think that clearly the evidence tells us some of the incentives are pretty simple, might be helping to reduce the debt from tuitions, for instance, could be incentives that would be actually looking again at working to maximum scope and providing regular hours, which means that we have the appropriate staffing in place. But I think also right across the board in the sectors that Mike talked about as being hit hard, many of our nurses who felt inexperienced were put in situations that were stressful for them. So I think what we need to do is have ongoing investment in the ongoing development and professional ongoing development so that we can teach on the fly, which we've learned in COVID, but in a way that nurses as well as other team members are feeling safe.
Thank you. I have one quick question, about a minute and 15 seconds left. Another one of the recommendation that was made by the association seems to demand the creation of a national healthcare workforce body that collects data and support health workforce planning at the regional level. We heard similar recommendation from CMA. Can you please explain the key benefit of such a data collection tool, both at the regional or at the municipal, at the provincial as well as the federal level? Thank you.
Thank you, Mr. Chair, for the question. First, I want to give you the fast answer. We collect data across the country. So, for example, we know there are 349,000 nurses, and these are the areas that they work. What we don't do is articulate that and make it interoperable with what are the physicians doing, what are the needs in communities. Are those 349,000 nurses doing the right thing? Like if someone asked me today, is there a nursing shortage? I say, well, there's 350,000 nurses and 95,000 docs. I don't know. Tons of them are working part-time. Like what if they were working full-time? There's a lot of what if. So our plea for an agency or a structure where we bring data together, planning together, is to talk about what does society need, who can best meet it, and then how many of those do you need?
Thank you, Mr. Villeneuve and Mr. Johari. Next, Mr. Lake, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses. This has been a great meeting. We heard a lot about how the funding situation needs to be resolved. I think that if you take a look at the platforms of our respective parties, we all recognize that. Pulling up a chart here of funding for the last 30 years, and we've been on a pretty solid trajectory since looks like about 2003-04. Faster than growth of transfers, faster than the growth of the economy, but the devastating cuts, if you take a look at the chart from 93 to 2001, is it fair to say we've just never caught up to the impact of those cuts? Maybe Dr. Kassam to start.
Yeah, thank you for the question. And absolutely, when we think about Canada Health Transfers and the fact that it's now sitting at close to 22%, at least in the province of Ontario, as far as shared spending, It simply isn't good enough. We've called for an increase. It's why we stand in solidarity with all of the premiers. I believe at the last Council of First Ministers, all of the premiers were there, basically advocating for an increase in Canada Health transfers. And the reason why that's important is as that money then flows to the provinces, we can then address a lot of the issues that we've actually brought up here in this chamber today. And so absolutely it has not met the needs of a growing and an aging society that we unfortunately have in this country, and it's a beautiful country. And we need to be able to sustain the level and quality of care by having commensurate investment in these areas.
Dr. Kassam, I'm going to stick with you actually, and in that vein, I mean, we're all inundated, especially at this point in time, with asks for massive new amounts of government spending. The government's going to have to say no to significant good asks given our spending situation, which is pretty challenging here in Canada, if we're going to say yes to dealing with this crisis in health. As we do that, thinking about technology, thinking about how to get more with the dollars that we are spending. So we acknowledge we're going to need to spend more. Our party's platform projected $60 billion, I think, in additional spending over 10 years. But can we leverage technology to improve the quantity and quality of care delivered? And I'll ask a second question in parcel with that is, can we also use technology to improve the system to avoid the burnout that all of you have spoken about?
Absolutely, very astute questions. Let me take the first one, which is, can we use and leverage technology innovation? Can we scale up and level up in this country our ability to deliver service, i.e. healthcare services, to the people that need it at the time that they need it? Absolutely. We saw what happened during COVID as far as virtual care. Yes, we're talking about appropriateness. Yes, we as a profession need to figure out what is appropriate and what is better served for patients in terms of in-person care. That conversation happens in real time, and in fact is being grappled with not only in this country, but frankly around the world. Excuse me. And so absolutely, I do believe, and we've seen this actually take place in a robust way in this province, at least in Ontario, throughout the past 24 months. And one of the things I think is important to, or hopefully important to recognize, is that as we start thinking about a recovery and a rehabilitation in our society post-COVID, and we're still here, and we're still dealing with the aftermath, of course, and making sure that we're trying to prevent a next wave. But we can't have an economic recovery without a healthcare recovery. And this is sort of where we think that investment is so very important, and using technology to leverage our ability to do so is extremely crucial. And then to your second point or question, which was about, can we use technology to help with system level change to reduce burnout? I absolutely hope so. We actually know that technology in some capacity is actually a driver of burnout. I'll give you an example. We as physicians, we have electronic medical records that are often not connected to one another. And so having to click through a bunch of different sites and different sort of areas, that actually can contribute to burnout if that information is not available to a provider in real time because it's on a different network, for example. So if we can have this integrated in a very hopefully meaningful way, we can actually reduce burnout, have doctors be doctors, continue to see patients and see more of them, and also reduce the administrative burden that is actually a driver of burnout in the sector.
Thank you. How much time do I have left? 20 seconds. So I'm not going to ask a question. I'm just going to make a comment to Ms. Vance. I come from Alberta, where I live in that world where I can go to my pharmacist and get help that I would, if I was in another part of the country, have to go to the doctor for, and it is fantastic. So talking about innovations, some of the innovations aren't necessarily technical, but systemic, and so just reinforce some of what you're saying. Thank you.
Thank you, Mr. Lake. The last round of questions will come from the Liberals. Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. I would like to share my time with Dr. Pawlowski. Thank you all the witnesses for your valuable information. My question is mainly to the OMA. We heard at the previous meetings that the one issue contributing the worker shortage with the provincial regulatory bodies. They make a difficulty to move between provinces and to admit the foreign trained professionals, especially IMG. We heard from Dr. Murphy 60,000 nurses shortage by 2022. We have a lab technicians. There's only 5 medical laboratory education program in Ontario, and all have waiting list. And we have a shortage for PSWs. So, and Dr. Kasim, you said creating residency support and recruitment, we need a multilateral approach. What do you think, what is the best strategy and the best practices so we can create more residency support places where our IMG or they can have places here? I know some of the students, Canadian students, the IMG, they did even Kingston Hospital elective, but they're waiting for the residency spot. So what can we do to fill those gaps?
Well, thank you for the question. And there's no question that there are bottlenecks in being able to be credentialed from an international medical graduate perspective. And this is something that comes up quite commonly in our discourse as we think about a health human resource strategy for the future. And of course, an international approach is very important. I think where we think about being able to match not only the supply of IMGs, for example, but also the demand where in terms of what kind of physician and where is appropriate. So for example, it would make absolutely no sense to train more surgeons without a commensurate increase in the ability to have those surgeons operate, because right now we have a limitation in our ability to have surgeons operate because of operating room time and the numbers of operating rooms that are available. So just simply credentialing more surgeons is actually not going to make the problem better. It's going to make it worse. You're going to have more unemployed specialists. And so it's really a matter of identifying need and then the scope of practice based on a jurisdiction, and then being able to then tie that into a minimum threshold of competence that is sort of the task of a federal body like this, but also perhaps a task force that would be required to better understand those trends. And
Dr. Pawlowski? Yeah, the problem in my mind is pretty simple. We don't have enough primary care practitioners to work in rural areas. We haven't for the past almost 35 years since I graduated from medical school. The other problem is now not having enough nurses. It would seem to me the problem could readily be solved by looking at credentialing far more foreign graduates. I know in my 35 years of being a doctor, I've met so many people, doctors and nurses in Canada who are trained in other places, but are unable, despite all their efforts to get credentialing in Canada. It would certainly seem to me, if we want to address the healthcare shortage quickly, what the federal government could do would be to give more money to the provinces, and the provinces then to implement more positions to upgrade the skills of foreign trained grads so that they come up to the standards required in Canada. That may mean academic upgrading, it may mean practical upgrading, it may mean more residency programs. But could we do that? And let me first ask Dr. Pecora, could you at Kingston open up more positions for academic training, maybe just a year or two, maybe shorter, depending on where the person's graduated from? Could you provide a kind of tailored, practical upgrading if necessary in order to get practitioners out quickly? And presumably they still have to write the licensing exams. But and I'm not thinking for surgeons because, yeah, the problem is not enough OR spots, but I'm thinking primary care practitioners and nurses.
So yes, we would certainly try to do this and work with the universities and the colleges to support it. You know, primary care is an interesting one because we have a very large family medicine program here, but it's a distributed education model, and they have placements all over Ontario and beyond. So they don't just train in Kingston, and so we need to, you know, take advantage of models like that. We've got a lot of hospitals in the province where surgeons could go to receive part of their training. We do that some already with Lakeridge, for example, but there's probably a lot more opportunity to do that than we take right now. But the downstream effects are significant. One of the biggest concerns I hear about is in the physiotherapy and occupational therapy training programs, where they just can't get access to enough clinical placements that they need to finish their training. And so there's, you know, it's not just physicians, it's nurses and others.
Thank you, Dr. Pecora and Dr. Pawlowski. That completes the round of questions. I want to offer a sincere thanks to our witnesses. You're all very busy professionals. Your expertise is evident. We will benefit from it greatly in our work on this study. I know I know that we would like to have you here longer. It's too bad for the interruptions, but we certainly got quality, and appreciate you sticking around and being so generous with your time. So thank you very much, everyone. Is it the will of the committee to adjourn the meeting? We have consensus. The meeting's adjourned.
Thank you.
Thank you.